respected panelist and moderator, and dear audience. Assalamu alaikum. With the permission of the chairpersons, now welcome to my topics. Mitra clip, what we should know. Mitral regurgitation is one of the most common heart valve disorder. Chronic mitral regurgitation is significantly public health burden. More than 3 million people suffering from moderate to severe mitral regurgitation. Surgical repair or replacement is the established treatment for degenerative mitral regurgitation, and patients with associated comorbidities or left ventricular dysfunctions are very high surgical risk, need less invasive and safer option. Mitral clip system developed in 1998 by Sengor. Feasibility was first demonstrated in animal model and first performed in human by Dr. Jose in 2003. Mitral valve consists of annulus, anterior and posterior mitral leaflet subdivided into A1, A2, A3 and P1, P2, P3 scallop segment. Chorda tendineae, papillary muscles and commissures. The aim of percutaneous strategies for mitral valve repair is to provide relief from severe AMR in patients who are not eligible candidate for surgical correction or who prefer a less invasive approach without the need for cardiopulmonary bypass. The percutaneous therapeutic options are end-to-end double orifice leaflet repair with the mitral clip system, coronary angioplasty, direct mitral angioplasty, hybrid ring angioplasty, percutaneous chorda implant, vascular remodeling device, and percutaneous mitral valve replacement. The mitral clip systems is a minimally invasive heart valve repair procedure. Implanting the clip in the heart without opening the chest, the best studied percutaneous mitral valve repair based on Alferi stitch operation between P2A2 segment mitral clip system is selected in patient significantly primary mitral regurgitation and also significant secondary mitral regurgitation with heart failure remains symptomatic despite guided directed medical management. Recently, ACC and AHA guidelines recommended class 2B level of evidence B consideration of transcatheter repair for severely symptomatic patients with chronic severe primary mitral regurgitation, reasonable life expectancy and surgical risks attributed to severe comorbidities. This procedure considered in moderate to severe AMR, pathology in P2 and A2 areas, coaptation length more than 2 mm, coaptation depth less than 11 mm, filial gap less than 10 mm, filial weight less than 15 mm, mitral valve orifice area more than 4 cm square, and mobile leaflet length more than 1 cm. Is contraindicated, patient not tolerated the procedural anticoagulation and procedural antiplatelet regime, rheumatic mitral valve disease, active endocarditic valve disease, and evidence of intracardiac, infravena cava and femoral vein thrombosis, and functional mitral regurgitation cases, ejection fraction less than 25% and left end systolic dimension more than 55 mm. This procedure is done usually under general anesthesia with the guidance of fluoroscopy and transesophageal echocardiography. And usually in the right femoral axis and heparization with ACT level more than 250 to 300 and perioperative antibiotic as per policy. Usually done in femoral vein root, and mitral clip system consists of steerable guide catheter and clip delivery system. The procedural steps usually done with a multidisciplinary team, heart team, and before doing this, the baseline imaging should be taken regarding mitral valve morphology and anatomy and calculation of the gradient and size of the annulus. Then with transseptal puncture, usually puncture in the posterior superior part of the intratracheal septum, and at first confirm the location, and safety consideration is most important. Steering and positioning of the mitral clip device very important. The clip delivery into straddle position, clip axial orientation above mitral valve annulus, usually in the center of the annulus. Then leaflet grasping, insertion and assessment and deployment is very crucial procedure process. And leaflet insertion, grasping and drop and clip arm closure, pre-deployment imaging assessment, tissue bridging and gradient and of the regurgitation is important. Clip release and post-release evaluation should be done properly. And then systemic removal of the whole system. The mitral clip device consists of MRI compatible cobalt chromium implant having 2 arms and 2 grippers, which are used to grasp the opposing edge of the mitral leaflets. These are the Mitra clip systems, the stabilizer which hold the whole system, the clip delivery system, and this is the clip delivery system, and the delivery catheter handle, and the steerable guide handle, and this is the steerable guide containing steerable sleeves and delivery catheter and the tip Mitra clip device. This is a Mitra clip knobology, guide handle for position of the anteroposteriorly, sleeve handle for medial, lateral or anteroposterior positioning, clip delivery handles for clip positioning, grasping and deployment of the mitral clip, and stabilizer for medial and lateral positioning. This is the guide knob. When you rotate clockwise, it curves the guide, and when you clock anti-clockwise, it straight the guide. This is the steering guide catheter. The mitral clip device dimension. Usually, we push the clip after opening 180-degree arms position. This figure is here the catheter system and clip are in the array under through the passes through the wire. This is the steerable guide, and the clip delivery system attached with the steerable guide system. This is the position of the clip in the left atrium. The manipulate and steering the clip towards the left upper pulmonary vein. This is the positioning of the clip, and is draw after opening, and in the LA is slowly draw the clip towards the mitral leaflet. This is a 2-dimensional transvisual echo showing the positioning of the clip. This is the ultimate result. These are the two opening formed after clipping of the mitral valve. This is positioning. If needed the second clip, it should be parallel to the first clip. The success depends on successful deployment of one or two clips attached to both leaflets. MRI should be less than grade 2 mitral regurgitation, mean tense mitral gradient less than 5 mm mercury. These are pre and post hemodynamics of the mitral leaflet, and in post clip the left atrial pressure diminished and BOFs abolished. This is the complications. The procedural adverse events are single leaflet device attachment 1.3%, device embolization 0.2%, major bleeding 3.7%, stroke 0.6%, and cardiac surgery is needed in 0.06%, HD closure needed in 1.6%. This is a trial of the mitral clip. Everest trial based on confirmed the feasibility of the procedure, and Everest 2 trial is based on safety and efficacy as compared those with surgical repair. Major adverse event is significantly less in mitral clip delivery in comparison to surgery. Greater need of blood transfusion in surgery. Death, mitral valve surgery, mitral severity greater than grade 2 is higher in surgery in comparison to mitral clip therapy. And subsequent analysis of this study and additional registry demonstrate persistent reduction of mitral regurgitation grade, improvement of NOSA class, functional class, and left ventricular dimension is reduced. These are the studies done in the world. More than 25,000 populations under these studies. Meta-analysis shows death, stroke, bleeding, prolonged ventilations, ICU days, and hospital days are significantly less in mitral clip procedure in comparison to surgery. Other devices usually used are Nicord, mitral spacer, mitral flex. Now conclusion. Mitral clip therapy is FDA approved for symptomatic patients with severe mitral regurgitations of primary MR or mixed MR who are poor surgical candidates. Finally, despite reduction of mitral regurgitations with either percutaneous repair or surgically functional mitral regurgitations has increased risk of long-term mortality. Newer devices have potential but are a long way off. Mitral valve, tense mitral valve replacement may be the future, but given the safety profile of mitral clip, there may be a role of both technologies. Thank you all for patient hearing. Thanks.